Hello, everyone. I am Ashley. I'm with MyEyes. I work with the doctors and offices and help them to educate their patients on the importance of home tonometry. Before we dive in, I wanted to give a quick intro to MyEyes for anyone that is new to us. So, MyEyes helps patients monitor their eye pressure from home using the eye care Home 2 device. We make the process really simple. We handle all of the education, training, and support. We work closely with your doctor so your readings are easy to understand and meaningful for your care. Our goal is to give you and your provider a clearer picture of your pressure throughout the day and night, not just a quick snapshot you get during an office visit. Since many of you here tonight or today are already curious about home tonometry, I also wanted to mention something really exciting. We're launching our Black Friday promotion next week. Um, but you guys get an early access to that, so it will be on the website. It will be $300 off the purchase, so it'll bring the price from $2,995 down to $2,695. If you've been thinking about having your own device at home, this is the best pricing we offer all year. You can also use your FSA funds, which you might lose if you don't use it by the end of the year, and also submit for insurance reimbursement. Another exciting update before we get started is we will soon be offering the PRS test that Dr. Khawaja will be talking about in his presentation. For anyone that wants to learn more or be notified as soon as it becomes available, which should be soon, we will be sharing in the Zoom link, a link in the Zoom chat. And then we will post that as soon as Dr. Kawaja starts speaking about that part in his presentation. So today we are thrilled to be joined by Dr. Professor Anthony Kawaja, PhD, FRC Opt. He is a leading glaucoma expert from the UCL Institute of Ophthalmology and Moorfields Eye Hospital in London. Professor Khawaja is an internationally recognized clinician scientist whose research focuses on the genetic and environmental causes of glaucoma, with the goal of creating better prediction models, improving early detection, and advancing personalized glaucoma care. He has completed prestigious fellowship training at both the University of Cambridge and Harvard Medical School. He has been honored with numerous awards, including the American Academy of Ophthalmology Senior Achievement Award and an NHS National Clinical Excellence Award. Beyond the clinic, he holds several influential leadership roles across the UK and Europe, shaping the future of eye care, data, and innovation. Fun fact, outside ophthalmology, he's a passionate musician who plays piano, composes, and loves exploring all genres of music. Today, Professor Kawaja will be walking us through some really important and often misunderstood topics around glaucoma genetics, including what the genetic code actually is and why it matters, how much of glaucoma risk is influenced by genetics, whether patients can learn their own genetic risk, what large genetic studies have taught us about the causes of glaucoma and future treatment approaches, and finally, how lifestyle factors may counter genetic risk. We're so excited for you to learn from one of the world's leading experts on this topic. Please join me in welcoming Dr. Professor Anthony Kawaja. Thank you so much.
Thanks very much, Ashley, and all the MyEyes team. It's a real pleasure to be with you virtually today. And I was given this title, Is Glaucoma in Your Genes?, which is something I'm very passionate about. I should point out I am an advisor to the company, and I presume it's this company that Ashley was talking about, through which you can find out your genetic risk for glaucoma if appropriate for you. So look, I don't need to tell this audience, but I think let's just set the scene here. What are the current challenges in the way that we look after patients with glaucoma, and how can genetics help us? So I want to go through some of those challenges. And one of them is that patients with the early signs of glaucoma often don't know they have it because there are blurry patches or patches which are missing that with both eyes open, people don't realize. And if you do wait till you realize, it's too late because you can't reverse this vision loss. And that's obviously very costly for the individual. It's also costly for health payers. In the UK alone, it's estimated to cost £28 billion a year to look after vision loss. You all know what glaucoma is. It's a disease of the nerve that communicates what the eye sees to the brain, but it's actually a disease in one particular part of it. It's in the optic nerve head. We're lucky as researchers in the eye. The eye is transparent, so you can actually look through the eye and you can see the optic nerve head there, and that's a very healthy one. And as people develop glaucoma, it changes in appearance. You get this cupping as the nerve fibers are lost, and that's glaucoma. How do we measure it as glaucoma's worsening? And can you measure that worsening vision loss? Well, you can measure those patches using a visual field machine that many of you, if your patients will have done, and this can measure how badly the glaucoma has affected the field of vision. We know the key parameter that drives vision loss in glaucoma, even in so-called normal pressure or normal tension glaucoma, is the pressure inside the eye, the intraocular pressure, and that puts a stress and strain on the nerve. I just love showing this because I think it's such great research, but this is using MRI imaging and showing how when your eye moves, it really puts a strain on the nerve that's connected back to the brain, and it's those biomechanical stresses on the nerve which are worse when it's held taut with higher pressure that causes the disease. And I'm reminded about this frequently when I'm at my desk. This desk I'm at now is a glass one, and when I look through it, sure enough, I see this, my plug here, and when I zoom in there, you can see this. It's actually just a physical thing. When you've got a cable attached to something, that's the point of weakness, and that's what happens in glaucoma at the optic nerve head. But let's just focus in on some of the challenges. One is that screening for glaucoma isn't currently recommended. So we've got a disease where people don't notice it in the early stages. By the time they notice it, it's too late. And there's so many treatments that could stop it going from the early stage to the late stage. So surely we should screen for this stage. Yet in the UK, it's not recommended. In the US, it isn't. There's the US Preventive Task Force. They don't recommend it. And that's a challenge. The other thing is that the risk of blindness varies. Not everybody with glaucoma is at high risk of blindness. That's represented in this moving graphic. Each dot here is a glaucoma patient in the United Kingdom, and how the dot is moving is how the vision is worsening in the right and left eye. So if you're a patient, you don't want to end up down here, because it means despite being looked after, you've ended up with poor vision in both eyes. And a problem for us is out of our thousands and thousands of glaucoma patients, we don't know which ones are just going to stay up here, and maybe they need less treatment and they'll have less side effects, and who's going to end up here. So we should really treat them more intensively or more aggressively. The last challenge I'm going to mention today is that treatment outcomes vary, and we've got many different treatments. Now, I'm not complaining. We need lots of different treatments to manage glaucoma. We've got drops, we've got laser, we've got minimally invasive surgery, we've got the more invasive traditional surgeries. But for each patient, how do we know which one works best? And, a lot of glaucoma care seems to be a bit of, well, let's try this. If it doesn't work, let's try the next thing, trial and error. So we welcome studies like this one that was done in the UK that compared drops first versus laser, selective laser trabeculoplasty first. And it showed actually that both are very good treatments. Laser might be a little bit better when you look more carefully. But the thing is, even though laser does well, it's not the same for everybody. If all patients were the same, this is what would happen. They'd have this average response. The eye pressure would come down, and that would slowly wane over time. But all our patients aren't the same. Everyone's individuals. And this is when you plot out the individual treatment responses, and you can see some patients do amazingly well. A few people get worse with laser, and then there's a whole spectrum in between. And at the moment, before we do the laser, we're not very good at predicting who's going to do really well. So in summary, one size doesn't fit all. So a lot of our studies in glaucoma have told us what's best to do on average. but none of you are averages. We're all individuals. And so how can we better treat individuals? And I agree with Barack Obama. When he launched the Precision Medicine Initiative, he was stood next to this. And this is a model of the structure of DNA, the genetic code. So what is the genetic code? Well, if you like, it's a set of instructions. It's a blueprint in our body that pretty much 100% tells you says what your color eyes are going to be. We've solved this really. So if I had your genetic codes, I could really very accurately predict with over 99% certainty what color your eyes are. It also, with about 90% accuracy, can tell us about hair color. Although I like this photo of Emma Stone because it reminds you that it's not how you look or your final phenotype, as we call it, doesn't just depend on your genetics. It depends on how you interact with the environment. Things that might be less well known, and other things that genetics predispose to, are things like your personality. And how empathetic someone is very much in the genetic code. And since I've learned this, I've actually sort of become a more accepting person. In years gone by, I might have said, well, I don't like that person. They're not very kind, or they're not very empathetic. Whereas now, if I come across someone like that, I think, well, it's probably not their fault. It's probably just their genetic code. Anyway, what exactly is the genetic code? I love this art installation in a museum in London. It's a medically themed museum. It's free to go to if you're ever in London, funded by the Wellcome Trust. And there's these rooms with really high ceilings, and there's this massive bookcase in there, so it's sort of much bigger than any of the bookcases probably in your homes. And they've got these huge volumes labeled 111, 222, all the way up to 22. You can see some of the volumes are open here, and they've got tiny print, like Bible-sized print. And when you zoom in, you can see it's kind of a boring book because all it is the letters A, C, G, and T. And that's the same for all of the books on this bookshelf. If we zoom out again, this is one human's DNA code printed out. So that's it. That's what the DNA code is. It's a massive bookcase of 3 billion letters, it turns out, A, C, G, or T. And depending on the order of those letters and what you are, tells you what you look like. It tells you how you behave to a certain degree. And it can also inform you about disease. And what's incredible is that at one point, say at this point in one of the books, there's a letter C. And if that were to just change to a letter A, that on its own might be enough to cause some types of disease. So diseases you may have heard of, like cystic fibrosis, sickle cell anemia, and most famously, I think, breast cancer. There are some changes where just one change in one letter of the 3 billion in the genetic code can cause an inherited version of breast cancer. And I think that's most famous because Angelina Jolie her mum passed away from breast cancer. She got genetic testing and realized she had that same variant, that same genetic mutation, and it prompted her to surgically have her breast removed to prevent getting breast cancer in the future. Now, diseases like glaucoma, while there are a small proportion of them, less than 5%, which might be caused by just one change in the genetic code, the majority of them are due to variants in multiple parts of the genetic code. So glaucoma is what's called a complex disease. And most common diseases are actually complex. Most breast cancer is actually not that type that Angelina Jolie had, it's the complex type. And that's where each individual risk factor on its own doesn't cause the disease, it just increases the risk of disease by a little bit. So many of these factors are common genetic variants. Many of you, all of us on the call, will have some of the genetic variants which increase the risk of glaucoma a bit. And then those of us who have glaucoma will have more of those genetic variants than those who don't. Now, identifying each of these factors is really tricky because there's lots of people who never get glaucoma that have some of the factors, and people who do have glaucoma don't have all of the factors, they've only got some of them. So to work it out, we've needed really big studies, and to do that, we've needed to be able to measure the genetic code in an affordable way. And the good news is it's just the cost of measuring the genetic code in people, it's just plummeted. It's been getting cheaper and cheaper. This is for measuring the whole genetic code, but you don't need to measure it all. You just need to measure markers in certain points across all of it. And it's become so cheap, you can do it yourself. So 23andMe, it's been in the news recently because I think maybe because they were doing everything so cheaply, but their business model wasn't working out. But they're back on secure territory now, and you can still do this. So I can go to my high street pharmacy and do it. If you are thinking of doing this direct to, so it's called direct to consumer genetic testing yourself, I would wait because there's always special offers, especially before Christmas. This was Christmas a few years ago. I think it's a bit more expensive now. But for a very cheap price, you can learn an awful lot about your genetics. One of the things you can learn is your ancestry. Now, my ancestry is a bit boring. It might be interesting to you because I might sound very English, but actually I'm 100% Lebanese. There's like really no doubt about my ancestry, but it can also tell you about your risk for diseases. And rewind back to when I was first starting my research, this was the list of diseases that they could tell you about, well, part of the list, and this was telling me about the risk. And back then I was like, well, glaucoma is such a genetic disease. Wouldn't it be great if in the future one day we could have glaucoma on there? And spoiler alert, glaucoma is on there, and I'll tell you more about that later. And that's due to some of the work that I'm about to share with you. So we've learned now that actually glaucoma is one of the most genetic of all of the common human diseases. We've known it's run in families, but we didn't quite know that when you sort of, you put it in a competition with all other diseases, for the common diseases, it's one of the most genetic. Now, when you do a genetic study to work out which of the variations in that DNA code that I showed you, by the way, we're almost entirely the same on that of those 3 billion letters, and there's sort of like around 1 million of them where we independently vary, and you can focus on those points and look at whether those variations are associated with the risk of glaucoma. And back in 2016, this was the best place we were at. And you summarize the results of these studies in one graph, which is nice because it's very visual. We call it a Manhattan plot. You may see why, because what you're looking for is skyscrapers. Going from left to right here is going from the beginning of the first book 1 to the end of book 22, all through all of those letters. And each dot is a letter in the DNA book which we vary at. And how high up it's plotted is how certain we are that that variation is associated with glaucoma risk. And this red line is the line of significance. So what we're looking for is things above that. And then we know, okay, this point, or especially this one, look at this huge skyscraper here. This point is very, very associated with glaucoma. And back in 2016, this was putting all the best studies in the world together. There were 9 points on the genetic code which contributed towards glaucoma. We were so excited. A lot of these, the ones in bold, we didn't know about previously, and this was groundbreaking. But when you only know 9 points in the genetic code, it turns out you really still don't understand the disease. You don't understand the complexity of it. If you think of those individual arrows, you don't have enough of them, enough pieces of the puzzle to understand what glaucoma is, or to be able to make useful predictions from the genetic code about glaucoma risk. So the real game changer came from the UK, actually. There's a study called UK Biobank. And now there are other biobank studies inspired by this. But back then, there was no study of this size, and it was very ambitious. A study of 500,000 people recruited across the United Kingdom, funded largely by the UK taxpayer and UK charities. And I always give a shout out to Professor Serpen Kaur and Professor Paul Foster, who from Moorfields and UCL, who lobbied and said, eyes are really important. You should have eye measurements in the study as well. And so for the last 100,000 or so of these 500,000 participants, there were eye measurements. Now, when you're measuring so many people, it's expensive. It's £500,000 per minute back then. It's probably £1 million per minute now. And so they had to do a video, this is a sped up version of it, to show that we could do 6 tests in 10 minutes, because that's all we had, 10 minutes. And that included doing the pressure in the eye and an OCT scan of the back of the eye. So with this huge study now, where did we get to? Well, this was the Manhattan plot. And the line of significance is all the way down here now, because now you've got some super significant parts of the genetic code. And this is looking a lot more like Manhattan now, right? There's a lot more skyscrapers up there. In fact, there are over 100 of them. And so this now was a real big step change in our understanding of what are the genetic causes of glaucoma. One thing you can start to do is look at patterns in all of these things, because a lot of these signals are in genes, and sometimes you understand what the genes do or which genes work together. So one of the interesting things was there's a lot of genes about development of anatomy, early development. And this has led to this idea that actually, while glaucoma often manifests itself, shows up when people are older adults, it's actually it's set up from when you were young, and maybe even in the womb. And it's essentially a lot of the time to do with the plumbing in your eye. And it's like if you've had some plumbing put in that's built to last 100 years, you're not going to get glaucoma. If you've had plumbing that's put in that's been to last 40 years, then you'll do fine for the first bit of your life. But then after that, as things start to fail and the pressure goes up, you can't handle the fluid that's being produced inside the eye, and then that puts stress on the nerve and causes glaucoma. So it's kind of already pre-written in your genetic code and in the development of we call it the aqueous fluid outflow system, or the plumbing inside your eye, that leads to glaucoma. The other big thing that this really challenged a dogma in glaucoma was the role, which part of the plumbing. People used to always say glaucoma was a disease of a part called trabecular meshwork, but these results pointed to Schlemm's canal. So you probably all already know how fluid flows in the eye from behind the iris, then it goes through the pupil in front of the iris, and then out through these structures. And this here, shining up now, is trabecular meshwork into Schlemm's canal and then down the collector channels. So it was always thought that the disease was here, but actually, for a lot of people, the number one pathway for glaucoma is not trabecular meshwork, it's here, it's Schlemm's canal and beyond. Now that's really important because some of our treatments only target this bit. There are some new stents that we put in the eyes, hydrous eye stent. There are some things where we cut, we do trabeculotomies, and that will work well in some people where the disease is mainly here. But if you're one of the people where the disease is mainly here, it won't work so well for you. And one popular example now is selective laser trabeculoplasty. So where I showed you before how different people respond differently to the laser, it could be that the people that don't respond so well are the people who have a problem not at trabecular meshwork, but at the Schlemm's canal. Now, the problem is our big studies with genetics don't have this type of data about how did people have laser, did they have drops, how well did they do, did they progress, did they get worse, how much did their pressure come down with laser. And so we haven't really been able to answer that question. So at Moorfields, we've started a bioresource where we're collecting this exact same data that we use to make these data visualizations and matching that with genetic data so we can start to answer those questions. And we presented some of those early results in one of the major eye conferences earlier this year called ARVO. This is my PhD student, Richie, And I'll just show you just his main graph here. We've developed a risk score for Schlemm's canal. So this risk score predicts whether your type of glaucoma is at Schlemm's canal rather than trabecular meshwork, and looked at the response to laser. And those people who had the high risk were more likely for the treatment to fail sooner than if you were at the low risk of having the Schlemm's canal type of glaucoma. So we're quite excited about this work, and hopefully we can share more of it in a published journal article soon. Now, coming back to this graph, our Manhattan plot, another cool thing that we can do now, this all looks very complicated, but actually you can just summarize all of that into one number. And if I had all of your genetic data, I could work out that one number for all of you, and we could plot it, and there'd be a distribution like this. And it's called a PRS, a polygenic risk score. And it's essentially a number that tells you your risk of glaucoma. And how well does that work? How well does the polygenic risk score work? Well, to look at that, we need to look at these things called ROC curves. And that's how, imagine here, the blue dot is people with glaucoma, the purple is without. We want the higher the area under the curve, and the more the curve is near this top left corner, the more you can distinguish between these two. And back then in 2018, we were getting, using just genetic data and age and sex, we could predict with 76% accuracy. And that was nothing close to that had ever happened, it had ever been seen before. So this was a really exciting result. Just to say, and I'll be showing you later a little bit on the new results, we're now getting closer to things like 83%, which is pretty impressive. But another way of looking at it is the polygenic risk scores. Imagine I'd done your polygenic risk score on all of you on this call. I could then divide you up into groups of 10, into the starting with those with the lowest 10% of the polygenic risk score and ending with those with the highest 10% of the polygenic risk score. And on the basis of just that, just the genetics, which I could have measured at your birth, I could tell who's got 15 times the chance of glaucoma to those with the bottom 10%. And these numbers have drastically changed now. We're getting actually ridiculous numbers, like even 200 times with the latest polygenic risk scores. But this is the most this is still the best that's been published in the journals. Now, why is that important? Just to say, if you're in the top 10% of genetic risk, it doesn't mean you'll definitely get the disease. And so a lot of people won't get the disease, but you're just at much higher chance than if you do. So it's not like taking the pressure and doing a scan and doing a field of vision. Those are diagnostic tests. This is a test to do before you've even had those, to tell you about your future risk. So it won't take the diagnosis. So why is it helpful? Well, if we want to screen for glaucoma, even if you've got a good screening test, if you apply it to the whole general population, glaucoma isn't quite common enough, is still relatively uncommon. And that means that even with a good screening test, way too many people that you'd be sending to the hospital won't actually have glaucoma. And that they could end up coming to harm with unnecessary treatment. But it also costs a lot, and it really burdens the healthcare system. We can't cope with that. But if we imagine a future where, let's say, we did have genetic data on everybody or on a certain population, you could say, well, let's not screen everybody. Let's just screen the people at the top 10% genetic risk. Now it's nearly 4% rather than 1% that have glaucoma. And the very same test then performs better. Then nearly half the people you're sending will actually have the disease and would benefit from treatment. So this, I believe, is going to be one of the first ways genetics can help us look after glaucoma. It can help us detect it, because at the moment you can't screen for it. But if with the aid of genetics and knowing a genetic risk score, you could target your screening to those at the high genetic risk, then that could work and then we could stop people turning up to hospital with already bad glaucoma because it was missed, it wasn't picked up early enough. Okay. A question I get a lot from my patients is, what can I do to help with my glaucoma? Okay, you want to do this laser, you want me to take these drops, but is there anything I can do in my life? It's an important question. The other thing is in the future, when we do have more genetic data, just healthcare systems have it, I'll come on to that. Someone might be told you're at high risk of glaucoma years before they have the disease. So wouldn't you like to know which of these sorts of factors could reduce your genetic risk of glaucoma, reduce that risk? It could mitigate, it could counter, as Ashley said, that risk of glaucoma. Well, we found this very interesting, and we put together a modifiable risk factors for glaucoma collaboration, including Lou Pasquale, who I believe did a webinar with MyEyes yesterday, a nutritionist I work with in Denmark, and some people in France, and a great group of people. The thing we were most interested in was caffeine, because that was something that actually all of us researchers enjoyed consuming. And we looked in the big UK Biobank study. In that study, they asked people about coffee and tea and how much they drink. And if you're curious as to what my fellow UK population, whether they like coffee or tea, well, I think we're true to our reputation. I'm a tea drinker, so are most of UK Biobank, less so coffee. What's quite staggering, I think, is nearly 1 in 5 people in UK Biobank report drinking 6 or more cups of tea a day. This my American colleagues thought was gross. When UK Biobank participants who said they drink coffee were asked to report which type of coffee they drink, mostly it was instant. I think that might have changed now. Starbucks has come over to the UK. I think people are more into their ground coffee now, but back then it was instant coffee. But actually, even if you just stick to drinks, in the US, in the UK, we get most of our caffeine in drinks through tea. But in the US, actually, you mainly get it through soft drinks, through things like Coca-Cola. So it's not just tea and coffee. And actually, there's a lot of foods that contain caffeine. And so in UK Biobank, a subset of people also filled in these dietary questionnaires that were sent regularly. And there was actually 19 foods and drinks that contain caffeine. And with the help of our nutritionist, we calculated the average caffeine consumption for all of these participants. And what's really interesting is that those who reported greater caffeine intake had a higher eye pressure, but only if they were at the highest genetic risk, not really otherwise. And this is what's called a gene-environment interaction. You don't need to worry so much about that, but it seems as though if you're not at genetic risk of glaucoma, drinking caffeine didn't affect your eye pressure. It's only if you're at genetic risk of glaucoma does the pressure increase. And it was a similar story for just whether you had glaucoma or didn't have glaucoma in the UK Biobank study. It was only those who consumed most caffeine and were at the highest genetic risk did the amount of glaucoma jump up. It's called a gene-environment interaction. Now, you don't have to understand everything on here, but we believe drinking caffeine makes your eye produce more fluid, more aqueous. Now, if you've been blessed with the genetic code that gives you a really good plumbing system, produce more fluid, fine, just drain it away. If genetically speaking, you've been given a less good plumbing system, produce more fluid, your eye can't cope with it, and the pressure rises, and that puts more strain on the nerve. The next thing we were most interested in was alcohol intake. And this was Kelsey Stewart in my group. He's now completed his PhD, looked at this, and this is without genetics. You can see greater alcohol intake. You don't need genetics. You can see it's got higher eye pressure, higher chance of glaucoma, and thinner nerves when you do the OCT scan. So maybe you don't need genetics, but actually, if you look at genetics here, this is the highest genetic risk, the lowest genetic risk. It's the greater eye pressure with greater alcohol intake is more marked with those at higher genetic risk. And if you're lucky enough to be in the bottom 20% of genetic risk, it seems as though you can drink as much as you want without having a higher eye pressure. Now, these studies are really, really complicated. And part of the problem is we can't measure diet very well. And so I'm hoping in the future we can maybe just take a photo of what we're eating, and AI, artificial intelligence, could help tell us what we eat or drink. This is a colleague of mine who's always posting on social media the food that he eats. It irritates lots of people. I don't mind personally. Another way, I don't know if you have this in the States. In the UK, we have these loyalty cards, which gives you discounts when you go to the supermarket. This is one of our biggest supermarkets, Sainsbury's, and I do my loyalty card, and then at the end of the year, it tells me, you know, what I've consumed. And these are the things that I bought most for the last year. I took home 200 portions of fruit and veg, and so maybe we could look at this data in relation to glaucoma, and it could tell us about things. Something quite striking came up here, because the other thing I got told was that in this major supermarket serving a big part of North London, I was the number 17 buyer of a very high brand containing cereal. Now, my wife doesn't even eat this, so it's all me. And so I was amazed that I reached that statistic. But here's another problem with studies looking at diet, is when you know you're being watched, you change your behavior. So knowing this, that I was the number 17 buyer, and I didn't even always buy it at the supermarket, for the year afterwards, I made sure I always bought it at that supermarket. And I'm very proud to say that the following year, I made it into the top 10. So speaking about AI, as I did, one thing that we can do now is automatically measure how bad glaucoma is from images at the back of the eye using AI. And we've worked with Google to develop an AI algorithm that could do this. And when you do that, and use that to help your genetic studies, look at this Manhattan plot now. It's gone really quite crazy. I would say even busier than the Manhattan skyline. One thing I should say is a lot of our studies so far have been mainly on people of European ancestry. And so kudos to many of my colleagues, including Yinka Sola and Mike Hauser here, who are leading a massive study in Africa to get more data on people with African ancestry. But really, this type of work is the coming together of lots of people. This is the International Glaucoma Genetics Consortium, including Lou Pasquale, who talked to some of you yesterday. In Europe, we've got a screening task force to bring in the genetics from the European Glaucoma Society and the European Eye Epidemiology Consortium. So it's us all working together, really. Lastly, I just want to say, you know, everything I've talked about so far sounds, you know, is it just research? Is it all quite futuristic? Or can any of this apply to glaucoma care now? So when can we use genetics to help us reduce blindness from glaucoma? Well, the answer is now. Actually, the direct consumer test 23andMe gives you now, it gives you your polygenic risk score for glaucoma. So that thing I wished for years ago has actually come to fruition. It was one of the first polygenic risk scores that they did, actually, and I'd like to think that was inspired by our work. This is mine. Fortunately, I'm in the typical range. You have to subscribe to a higher level of 23andMe to get this. I can't personally tell you how good their polygenic risk score is. It's not, we haven't validated it in our studies. So it's there, but it's hard to know how good it is. They give you advice if you do have a high polygenic risk score. They say limit caffeine consumption, which based on our work. Which one is validated is from this company, as I've said, Sionix Bio. They do it via a saliva test, and it needs to be ordered through a physician, either your physician or I actually didn't know that, Ashley. That's amazing that MyEyes are going to help patients or relatives of patients or healthy people who are concerned about their future risk of glaucoma be able to find out, you know, one of these most important risk factors for glaucoma, the polygenic risk score. And there's two reports. There's one report that goes to the doctor, the clinician. And there's one which is made in a simplified way that goes to the patient or to the healthy person who wants to know their risks. So it's great that that service is now out there. Another way that we're going to get genetic data in the future is when a healthcare system or a country even decides we just want to do it. So Iceland actually have genetic data on half of their population. Finland on about a third. In the UK, there's a study that's undergoing, it's halfway through, it's aiming to do 5 million. They've done 2.5 million adults. And that's over 10% of adults in the UK. And I think this is going to pave the way for everybody in the UK to have their genetic data taken, because we've got a big national public health service, and they could store the data, and then like eye departments can interface with the data to work out risk of diseases and so on, eye diseases, or the National Health Service can look, oh, who's at high risk of glaucoma? Let's just invite them for screening and so on. So hopefully I've convinced you that genetics is going to help us screen for glaucoma in the general population, which we can't do at the moment. So we could screen those at high genetic risk. We can predict who's at highest risk of blindness, so we can treat them differently to those who are at low risk. We can, for once, predict which treatment's going to work best for which individual, rather than the trial and error approach we have to use for glaucoma now. And I think genetics is going to inform the lifestyle advice we give patients too. Now, this is some of my research team. We left the UK. We actually went to Albania because it was very affordable, together with lots of data to do the next big genetic association study. It's not published yet, but I'll give you a sneak peek of the new Manhattan plot, and it's just getting crazier and crazier. And with this, the polygenic risk score just keeps on getting better and better, and I think will be more and more useful as time goes on. So I'd like to acknowledge, as well as my research group, the people that fund my research, and thank you very much for your attention.
Thank you so much, Dr. Khawaja. I'll bring myself up here. Oh, you can't start the video. That's fine. So this is Erica from MyEyes. I've talked to many of you many times, and I'm going to just fire up the questions that you've all put in the chat. The first one, how early should family members of someone with glaucoma get tested?
There's no easy answer to that question. In the UK, you can get a free eye test if you over the age of 60, because as you get older, you get more likely to get diseases like glaucoma. But that gets reduced to 40 if you've got a first-degree family relative with glaucoma. And 40 seems to be that sweet spot. But what I tell people when they ask me that question is, well, it also depends on your family. If your family history, it was people were getting the glaucoma in their 20s, you know, I would start about 10 years earlier than when your relatives do. And if everything's absolutely fine, then maybe you don't need to go back for another couple of years. If things are a bit uncertain, then you keep going back every year. The thing is don't leave it as long as, you know, I once didn't go to the dentist for 7 years or something. We can all get very busy with our lives. If you've got a family history, or if you find out you've got a high polygenic risk score, you know, you won't know if you've got the early signs of glaucoma. You know, go, especially once you've reached the age of 40, go every year. My mum's got glaucoma, so I go every year, despite my polygenic risk score being in normal range.
This one, kind of, thank you, that piggybacks off of that. I have a strong family history of glaucoma and have been diagnosed myself last year. Can the PRS tell the severity of the glaucoma?
So there is some research that suggests it can. The strongest thing seems to be that people with a higher PRS are more likely to get glaucoma at a younger age than those who have a lower PRS, and also more likely to go on to have surgery. Now, I don't know whether in those studies it's just people that have been doing more surgery because the patients were younger, potentially. But there seems to be something there. I think there's going to be more PRSs in the future that are going to be better to predict the severity. It's something that many of us are working on at the moment. I would say the current PRS, like the one Sionix gives, the thing it is completely amazing at, and something that we've never been able to do before, is tell you your future risk of getting any type of glaucoma. And I think something that it's quite good at is saying how severe it's going to be. But I don't think it's strong enough that if you've got glaucoma and you've got a lowish PRS, I don't think you should be really reassured and think, well, I'm not going to take my medication. I don't think we're at that point yet. I think you should still be treated according to how your physician says. But if it's sort of borderline, I don't know whether to have surgery or not. Having that information might be an extra thing you can take into account to help you make that decision. Do I take the risks of surgery or not? Maybe if you've got a high PRS, you'll think, well, this suggests things might not be going the way I'd like them to.
Okay, great. Do most eye doctors perform the PRS test? It's probably
No,
different in the UK versus the United States at the moment.
Yeah, no, I would say most don't at the moment. This is
Yeah.
quite a new thing. So in the UK, we don't have Sionix Bio, the company that are doing it in the US and in Australia. They're not doing it in the UK yet. So we don't even have that option. I believe what's going to happen in the UK is, we're working with that Our Future Health study, and we're going to do a study within Our Future Health to look at whether glaucoma screening can work, but then eventually link it to the hospitals as well, so we can help try and personalize our care, who should have laser, who should have drops, who's going to do well with surgery, and predict who needs surgery as well. But that won't be the eye doctors ordering it. That's going to be our overall health system doing it, because remember that genetic data isn't going to just tell you about glaucoma, tell you about all eye things, including macular degeneration, diabetic retinopathy, but it's also going to tell you risk of cardiovascular disease. Should you take a statin or not? Are you going to get side effects from a statin? You should take a different cholesterol drug. What's my risk of, when should I start screening for breast cancer? Should I be screened for prostate cancer, or should I delay that because I'm at low risk and I might just have to have unnecessary interventions and the risk of those things? And so it's, if an eye doctor orders it, it's I think still good value, but it's not realizing the full value of it. So I think in the UK, where it's a public health system, which is often starved of cash, I think that's the way it's going to happen.
Great, thank you. Do you have a list of SNPs we can look for in our 23andMe data to see which glaucoma risk SNPs we have?
Yes, they've all been published, the top ones, but actually the best polygenic risk scores now involve all of about 7 million of them, and puts it all into a formula. Because while in the published literature you'll see those genetic variants, I prefer to say that than a single nucleotide polymorphism, because there are different types of genetic variants actually. So these variants, those are published, and you can, if you're that keen, you can download them and look at them, and you can try and work out the formula yourself, no problem. But actually the best formulas look at the stuff under there as well, because even though we're less certain that these genetic variants are definitely associated with glaucoma, they're still on average going to give you some information rather than no information. And the best polygenic risk scores use all of that information as well.
Are there any specific guidelines or genetic markers for pigmentary glaucoma?
No, not so much. There's been a couple, but it's not so, it's unfortunately it's less common. And as I was telling you, this complexity of the disease for any complex disorder, and pigment dispersion syndrome is complex. So sometimes it runs strongly in families, but a lot of the time it doesn't. And it's just not quite common enough for us to have so far collected enough So unfortunately, we're a bit behind on pigmentary glaucoma. Pseudoexfoliation glaucoma, on the other hand, has been just about common enough, and there has been some big studies on that. And we're now nowhere near primary open angle. I mean, we're not near the hundreds that we are for primary open angle glaucoma, but we've got a good handful for pseudoexfoliation glaucoma. In fact, the first genetic association study for glaucoma to find something was for pseudoexfoliation glaucoma, and it's a very common genetic variant in a gene called LOXL1. We still don't quite understand how it causes it, but it's a very major cause for that type of glaucoma.
Fascinating. I'm of Japanese descent and have read that we are at higher risk. Is this true? And will I pass it on to my children who are half Caucasian?
I'm not sure that there is a massive difference in terms of the overall proportion of Japanese people versus, say, Europeans. What is different is that Japanese people seem to get glaucoma with pressure within what's called the normal range, which is under 21 millimeters of mercury. Now, that's contested and debated as to what that is. Is it that the nerves of Japanese people are more vulnerable, and that's why even at lower pressures they get glaucoma? Or is it that we just measure the pressure differently because Japanese people have slightly different corneas, and we always measure the pressure by saying how hard does the eye feel? I think it's the latter, and I think there's some evidence that suggests that. But overall, I don't think there is a big difference in risk. There are some large genetic studies in Japanese people, and there's actually a lot of overlap between the genetic causes in Europeans and Japanese people. And future polygenic risk scores need to handle this issue that you're not going to, sure, you can get a polygenic risk score for Europeans and one for Japanese people, but what if you've got people who are a quarter Japanese, a quarter African, and half European or something? How do you handle that? And there are methods now that do that, and they actually go through the genetic code and say, well, this bit here looks Japanese, we'll apply the Japanese polygenic risk score to this bit. Oh, and this bit looks European, we'll apply the European one to that bit. And it's all so rapidly developing. So I hope to see pretty good ones that do that type of approach within the next 3 to 5 years.
Great. Does PRS help in the decision of what type of surgery to use as glaucoma progresses?
So far, I would say no for the standard PRS, but I would hope that our PRS that I showed that points towards Schlemm's canal being the problem, I hope that would, because there are some surgeries which aim to just bypass the trabecular meshwork. There are little stents called like iStent or Hydrus stent. There are things where you can do a trabeculotomy, and there are many procedures now that aim to just bypass trabecular meshwork. But if you've got a high score on this thing saying you're likely to have a problem with the Schlemm's canal, then maybe those treatments won't work so well, and you'd be better off moving on to a new to a different treatment. So that's the theory. But at the moment, we don't have very big data sets where we have response to surgery data together with genetic data, but they are coming.
Okay. Are people of South American Indian descent also at increased risk of low pressure glaucoma? It's a big question.
Not to my knowledge, no.
We've had a few questions about caffeine and the amount of caffeine that is acceptable. If somebody, especially if somebody doesn't know their PRS score.
Yeah. Look, I'd say if you have glaucoma, then probably it's like you've got a high genetic risk for glaucoma. And if you're lucky and your glaucoma is stable, you go and see your glaucoma physician and they just say, yeah, you're fine on your treatment, then I don't see any reason to change. In fact, I don't mention caffeine to it. So if I newly diagnose a glaucoma patient or I've got a stable patient, I don't mention it to everybody because it's still not something that's proven beyond any doubt. We haven't done a randomized trial, and we'll probably struggle to do a randomized trial because maybe people don't want to be randomized to either having no caffeine or drinking 4 cups of coffee a day or whatever. So we may never have better evidence than this. But the time I bring it up is when I've got patients who are getting worse despite the best we're doing. And then I look at various other things. One of them's caffeine. There's also alcohol, also salt intake, also some types of medications. Some medications that people take for blood pressure. It's not proven, but our research shows might increase the risk. So we'll start to look at other things if everything else we're doing isn't working. But otherwise, people enjoy coffee. There might be other benefits from a coffee. I wouldn't worry too much about it. The best thing you could do is if you've got an eye care home, then you can measure your intraocular pressure. So you can measure it before the coffee and measure it after, shortly after, an hour after, 3 hours after, and see in you, what does it do? So if you're lucky enough to have access to an eye care home device, then that would be the best way of knowing for sure.
I can say as a glaucoma patient myself, that has been the case. I've had mine for 3 years, and you can definitely test different lifestyle changes and things like that and be able to know what it does to your IOP. It's invaluable information. So another one. And some of the questions in the chat are kind of very specific to people in their own disease, and we can certainly try to get you some of those answers after the fact. But I'm going to go to this one. I have glaucoma in my left eye. Is there a way to predict if it will manifest in the right eye?
I think if you've already got it in one eye, it's it would then be about the diagnostic tests in the other eye. I saw a patient yesterday who had terrible glaucoma in one eye and just nothing in the other eye. And that's very rare because it's usually mainly a genetic condition and genes affect both eyes. But there are some types of glaucoma, for example, ice syndrome, or others where it can be just very one-sided. Pseudoexfoliation glaucoma can be quite asymmetrical, but it often ends up eventually happening in the other eye. There are also sometimes people can get angle closure type of glaucoma, mainly affecting one eye. And then if they have cataract surgery in both eyes, having cataract surgery effectively cures you, prevents further damage. And so if you do that in the other eye, then that can, I think that's what happened to my patient. I sort of inferred from my patient yesterday.
Yeah, I can actually say as somebody who has secondary glaucoma in one eye, I did the PRS test to find out what my chances are of getting glaucoma in the other eye, just genetically. So that was super helpful information to have that. And let's see, we have Mark, I will definitely answer your question. We will be selling the site score PRS tests within the next couple of months. So we're working out the details on that. And that is the same one, the Sionix one that you asked about. So Dr. Khawaja, I thank you very much for all of your information. Fascinating, especially, like I said, for those of us with glaucoma. It's just great. And I thank you for the work that you've been doing, and you collaborate with amazing information. There's definitely an anxiety that goes along with glaucoma as well when we're dealing with our eyesight. So just thank you very much, and thank you for the information. And for those who leave other questions, we'll get to them after the webinar.
Okay. Well, thanks.
Thank
This
you
was
so
a
much.
pleasure. I really valued the opportunity. Thank you very much, everyone.
Thank you.
Thank you.
Thank you.